Good morning. It's just really a privilege to be here. I look at some familiar faces and it's just nice to see everyone. And I'm passionate about sleep as well as taking care of children and adolescents with Down syndrome as well. So the objective today is to review different factors that predispose people with Down syndrome to obstructive sleep apnea, as well as discuss the impact of untreated obstructive sleep apnea on health in general, but also specific to people with Down syndrome. Explain also how evaluation of obstructive sleep apnea can occur, and then think of some treatment options, although I'll also be followed by Dr. Keeley, who will also discuss other treatment options as well. So what is sleep apnea? It's a change in breathing when sleeping. It's not that you necessarily always stop breathing. There is some pauses in breathing, but it's also a partially blocked breathing is how I would think of that. And how I look at it as a sleep physician, it's a little bit different than adults versus children. When you look at a sleep study, it's greater than 10 seconds in adults, and it's 2 respiratory cycles in children. And why that is, most of us are probably parents in this room. We always know like an infant breathes faster than an adult. And so that's 2 breaths per is much quicker in a child, especially infant, versus an adult. The difference that we talk about sleep apnea, there's 2 different types. There's what's called obstructive sleep apnea, and that is breathing that's blocked by an obstruction of the airway. So you're still trying to breathe, but then the breathing is not really getting through as well. So you can see the chest and abdomen are moving. So that's the obstruction is usually in the upper airway somewhere. A central apnea, and we talk about it sometimes too, is that where their brain just is not signaling, and it's a pause. This is truly a pause in breathing. So if you're watching, some central apneas are actually very normal. So if you're just breathing in sleep, it would look kind of like that's kind of a very brief pause, and that's what a central sleep apnea is. And a hypopnea is really in the sleep medicine world, but this is probably the most common. It's a reduction in breathing or the airflow by at least 50%. And oftentimes there's a little bit of decrease in oxygen as well. So those are some of the terms you'll see on sleep study reports. Why would children with Down syndrome be at risk for sleep apnea? I mean, I'm in a very educated audience here, but there's different factors and everyone's different as well. But smaller mid-face sort of means this area with the maxilla, the jaw bones is smaller, as well as the hard palate. So the roof of the mouth is called your palate. And that is, if you have a relatively smaller space in your mouth area, the tongue can be relatively large for a smaller space, if that makes sense. Also decreased pharyngeal muscle tone. So the pharynx that's in your throat is made up of a collection of muscles, and the tone of the pharynx is just like in different parts of the body is also can be decreased. And so maintaining that shape to be breathing can be affected. Also, as many of you know, there's different frequent nasal and sinus congestion. So the airway would go from the nose and mouth to the throat into the lungs. So things that affect that airway, that airflow, can affect obstructive sleep apnea or breathing at night, just like it affects the daytime. And then if there's immunologic deficiencies, then you could have more frequent infections as well. Other reasons that can contribute to obstructive sleep apnea, dysphagia and reflux. So, which the next slide I'll kind of explain a little bit too, but the reasons for obstructive sleep apnea will change by ages. We all know an infant is not the same as a toddler, is not the same as a preschooler, is not the same as a teenager and adult, and that how your body grows and how your airway changes over time can affect that. There's also other airway anomalies, which Dr. Keeley may touch base on as well. Lower muscle tone in general, too. I talked about the pharynx or the larynx area, and then I just mentioned the different ages. So this slide is to kind of the differences, and the red dot is the tongue. And if you think of the tongue, maybe we don't think about it a lot. It's a really big muscle in a smaller space. And then the blue dot is where your vocal cord is. And if you look at the infant versus the child versus the adult, especially in the infant, your tongue and your vocal cords are really close together. So just like all of us, like that breathing and eating can be really challenging to coordinate. And that also affects breathing at night. But then as you get to the child age, that distance is getting a little bit bigger. And the dotted area is the tonsils and adenoids. And tonsils and adenoids do grow over time. They're not very big when you're born. They tend to get larger, and they tend to get larger more quickly in this like 2 to 5 year old age range. And again, if you have a smaller space and something's growing more quickly, it can cause challenges with the airway and obstructive sleep apnea. And then basically the adult, and you see that distance between the tongue muscle and the vocal cords getting larger. So there's different spaces, and also affects where the area of airway obstruction could happen. So this is a little bit of a different kind of view. Now we're on the side. And again, the tongue, that is that really big pink area in the middle. And it's meant to kind of show that this blocked airway is really behind the tongue, especially. And this is the palate. This is the area. And this is like your uvula, the thing that dangles in the back. That's kind of where obstruction is probably most common, especially in the adult population, but also in kids as well. Versus the open area is really also to demonstrate, we're thinking again from the nose, and the turbinates are the kind of this tissues in here if there's been turbinate surgery. And then kind of going behind again, and this is the palate and the tongue. And kind of thinking of all those different aspects of where you could have airway obstruction along that path occurs. Yes. So I've talked just a bit about central apnea, and I think it's helpful to touch base on it because you may see it mentioned in sleep study reports. Probably the most common reason to have central apnea in a child with Down syndrome is not, for some children, it's more related to other neurologic issues. Probably for children with Down syndrome, it's more related to that repeated episodes of obstructive sleep apnea can precipitate a central apnea. So if you're having trouble breathing and you have an obstructive apnea, you may have a pause after it. So you may be like snoring. So that was like having trouble breathing, a snore, and then you pause after. And so that's probably the most common reason. Another is kind of thinking there is some idea that there's a difference in neuronal sympathetic response. And so that some children with Down syndrome may not have the compensatory heart rate and kind of arousal wake up, as well as some other children. And so this could also predispose to some lower oxygen levels as well if your brain's not kind of making move around as much. So what's the health impact of sleep apnea? I mean, I think one, probably sleepiness is what we think of the most, or behavior issues, but other kind of comorbid or other things that can happen is also an increased incidence of pulmonary hypertension. There is, especially when infants are born with Down syndrome, there is pulmonary hypertension that can occur, but if it's prolonged, having continued obstructive sleep apnea can be a component. And I also think of how the brain is affected by sleep quality. So this is looking at verbal IQ scores, and cognitive flexibility can be impaired if you have continued sleep apnea, executive function as well. And then mood, right? If we haven't slept well, you mentally, it's harder to deal with the day. And so you can have increased incidence of depression. And I mentioned hypertension. There's two hypertensions on the slide. I think in the adult world, especially the cardiovascular effects with increased blood pressure or atrial fibrillation, which is really not so much as a component of children and adolescent sleep apnea. And I said already the sleepiness and irritability. Well, I put weight challenges because there is evidence that if you have ongoing obstructive sleep apnea, insulin resistance can be continued. And so thinking of, and also if you're tired, you don't really feel like exercising, or you actually choose food differently if you've had impact on your sleep. And so some of those also make it more difficult. So how common is sleep apnea in children with Down syndrome? I should have put in the pediatric population. It's probably 1 to 5%. We think of have overall children who have obstructive sleep apnea. If you have a child with Down syndrome, it's probably 60 to 100%. You may have it at different parts of life too. I just mentioned that life changes, a child changes over time too. So probably nearly 80% of children with Down syndrome have evidence of sleep apnea by 4 years of age from another study. And I think the other challenging part, especially counseling parents, is that you may not know it may look asymptomatic too. I said 50% in another study where parents weren't aware because the typical symptoms of snoring may not be present. And so I think that's really a challenge, and it's not at all anyone's fault. And this really is just like hard to pick up is basically what I would say. So again, really from the last slide too, is that the symptoms of sleep apnea I think of the most is usually heavy breathing or snoring. And I think of snoring in a child is different than, I think of my grandfather where I could hear him 3 floors away. And there was no doubt he had sleep apnea. That was not treated. But a child, you may need to actually be in the room to hear the heavy breathing or the changes of breathing, and you're sleeping too. And so it's a different way of kind of talking. So it's more of really maybe open mouth position, restless sleep is mentioned on here. Um, the daytime sleepiness and excessive napping can occur with obstructive sleep apnea at certain ages. I think the teenage population where they're more susceptible to sleepiness, school age maybe. I mean, and then it's really challenging as an infant and a toddler to know, I mean, they're supposed to be napping. So trying to figure that out is tricky. Sleeping sitting up though, I mentioned too, both sleeping bent forward at the waist where you're sitting up and actually your whole body comes over the legs is not an uncommon position in many children with Down syndrome. But there is a concern that that's a symptom of obstructive sleep apnea in a sense. If you're starting sleeping on your back and you have trouble breathing, you may sit up and then fall forward due to, and so then you kind of obtain that position of kind of a folded over position, which can be a symptom of obstructive sleep apnea. Sleeping with neck extended, if you, how that is that your body wants to breathe when it's sleeping. So if you see your child or even teenagers kind of an open mouth position and head, extended this way, because it kind of opens the airway in that sense, or even on the back, sometimes having like a preference to have a pillow behind the neck is another observation parents can have. Other things, irritability, poor attention, poor concentration. Again, it's not that sleepiness, it's that impact of not the quality of sleep on kind of dealing with your day. So evaluation for sleep apnea. This is probably, if you've gone through a sleep study, this is probably not your favorite slide. Overnight sleep studies are tricky. There is lots of stickers and wires, but it's a really helpful tool to really get objective information about sleep and sleep quality at night. And there is a lot of monitors that are on there, and the monitors are picking up brain waves. So there is a EEG part. It's also measuring heart rate, oxygen levels, carbon dioxide levels. There's a videotape going on. There's a microphone. There's airflow with the thing by the nose. So there's a good question of what the information we gather in the sleep lab is what is happening at home. And I think to some extent, yes, but you also need a good history with it too. And so I think that that's another reason to meet with someone like me to kind of talk about what's going on at home. And even the observations at home are really should be taken into account in the kind of the understanding of the information on the sleep study. So where does it happen? It does happen overnight in a sleep center in Madison. I work at Wisconsin Sleep Center. St. Mary's also has its own sleep center. There's other areas in the country, in the surrounding area that also do sleep studies. And ideally, it's a place that routinely works with children because this is a tricky test too for overnight. And then really the parent or caregiver should stay overnight and really, in my opinion, stay overnight in the room with the patient as well. So when should it happen? Before the age of 4 through the American Academy of Pediatrics really recommends at least one sleep study at that point. But I just want, there's a life changes, the child, teenager, adult changes. And so it's probably the first of maybe many sleep studies or maybe not, but kind of ongoing monitoring is important. And then what if you can't tolerate it? So I think we just talked about kind of applying the discussion about what's happening at home to a sleep study or sleep evaluation is important. But kind of what other options are there? Um, the phone has been added is a really actually great tool. So taking videotapes of what the sound, the breathing changes, the position, and you can look at those. And I feel like that's a really helpful tool because I can see what you're seeing at home. And so that's nice. There is overnight pulse oximetry too. So that's what the picture is. It's much less than overnight sleep study, and it's done in the home. And it's actually, there's not a cost to it either. And so you can apply that. And there really is some good studies looking at overnight pulse oximetry as a, not only a screening tool for obstructive sleep apnea, but if needed, can help in diagnosing as well. I think I'm on the next slide. The challenge with overnight pulse oximetry, it's at the end of the slide, is that if we're talking about CPAP as a treatment, overnight oxygen monitoring or the pulse oximetry doesn't qualify you for CPAP. So it's a good test for looking at obstructive sleep apnea. It just doesn't, if you're thinking of CPAP as the treatment for obstructive sleep apnea, you do need a sleep study for that. So I do get a lot of questions about home sleep studies, and if there are adults in the audience or adults with Down syndrome too, that is another option. I think, and I'll show on the next slide, there is some advantages to home sleep studies because it's done in the home as well, and there's less equipment, but it also is not very good at picking up mild obstructive sleep apnea, which is really probably the most common severity, I would say, in children and adolescents. So I think there's advantages, but there's also disadvantages. The picture, at Wisconsin Sleep Center, we have two devices. There is a Compass device, which I'll show in the next bit, has a nasal monitor and a pulse oximeter, but they kind of come off easily. And there's also a belt. And then the Watch Pat is an FDA approved device for 12 and older and for 65 pounds and older. I'll show the slide, it'll make more sense. So the Watch Pat is on this side, and it basically is a really tight finger probe and a wrist monitor, and then there's a sticker on the chest for position of your body and a snore. So I have used this, is that you have to have a big enough finger for it to fit tightly. And so that is something to kind of be aware of. It also, if you take that probe off too many times, it's really meant as like a one-time put it on your finger. So, I mean, that can be hard too, because I think, any person might want to take it on and off, and so it won't be quite as accurate. But it's worth trying because you can see that there's a lot less stuff on you. And then this is the adult, like the Compass. There's different home sleep sizes. This is just the current brand. This nasal monitor is really built for adults. So that's one of the disadvantages. And then this finger probe is again more of a adult style, but it's important to mention different options, I think, as you get older, especially for teenagers, for sleep testing. So treatment. Probably the most common, and we kind of talked about, is taking your removal of tonsils and adenoids. And cure rate of obstructive sleep apnea is about 50 to 70% of children with Down syndrome when they take the tonsils and adenoids out for curing obstructive sleep apnea. There's also lingual tonsillectomy, but I'll probably leave that more to Dr. Keeley to talk about. And that's another surgeries. And there are other surgeries, and Dr. Keeley's following me, so I did not list all of those on this slide. But other options, thinking again of trying to keep your airway open from your nose down into your lungs, heartburn or reflux or trouble swallowing. We looked at that first slide as with the infant, where the vocal cords, where your food is going and your tongue are all in this small little area. And so if you can help with feeding and reflux, it can kind of open that area up at certain ages and help with obstructive sleep apnea. Allergic rhinitis. So again, this is thinking of your nose and trying to keep your nose open can help with more nasal breathing and also that airflow down into your lungs. So nasal steroids like Flonase, if you have allergies, can help. Treatment of allergies. Antihistamines like Claritin or Zyrtec, which is also cetirizine. Even nasal washes too. And asthma, a breathing issue, but if we're trying to help, you don't want to forget about your lungs and taking care of asthma as kind of a lower airway, but again, that can also impact, I call it the upper airway as well. This mentions orthodontics. So rapid maxillary expansion, if anyone has heard of a palate expander. So again, that's the roof of your mouth. And I talk to people about the roof of their mouth is the bottom of their nose. And so if you have a small nasal airway, if we can make that bigger, that's where kind of expanding the roof of the mouth can help too. Weight management, because keeping a normative weight, because fatty tissue is deposited not only in like around the waist, but it can also impact breathing. It can impact the airway as well. And reassessment is important. Again, things change over time too. So CPAP, how does it work? CPAP is air going in the nose or the mouth. Here's normal breathing, kind of air going through. Snoring where you're having vibration through the nose or behind the tongue and the palate. And then obstructive sleep apnea, which I showed on a previous slide with the airway blocked. And then CPAP, this is meant to be a mask blowing on the nose and blowing the airway open. The mask can be on the nose or the mouth. It is tricky, right, to keep something on at night with something blowing in it. And it's not only just like air blowing in, it's having something on your head. Usually there's a headgear with it. There's the mask on your face. There's also, we go through sleep cycles at night. So it's not only keeping it on for the first hour, it's for like 8 hours too. So that's even getting used to glasses can be hard too. So kind of thinking of all those pieces is important, and even just how you're sleeping in general will also impact CPAP use. These are some pictures. So it can happen, but it does take a lot of work, and not only work from the child, but work from the family too. So process of getting used to it. You have a wonderful talk coming up after Dr. Keeley to thinking of other options to do that. I really think everyone is unique, and it can depend on not only the mask, the air pressure, but it can depend on definitely the child and also the family situation and time and other health issues going on too. So, I mean, this is easy. It says to really explain why to use it. You know, I think we've talked about why the benefits of treating sleep apnea is important, how to use it, and try to make it feel as comfortable as possible. I mean, whatever CPAP you do need to be able to fall asleep with it, to go back to sleep during the night, because everyone wakes up at night. So it would be lovely if we could sneak in at midnight and put CPAP on and they'd sleep the rest of the night with it on. But that just doesn't, you don't sneak in with CPAP, unfortunately. So I'm spilling the beans there, but it's just something you just don't do. So it is kind of really getting used to it is important. This is one video. You'll get other information too. The American Academy of Pediatrics put this video out a couple years ago. So it is nice. And this is just meant to like, the child is awake in their room, and that's a 2-minute timer, and success is in really small increments to really get the throughout the night. These are some other books kind of about CPAP and why it's helpful too. The Magical Mask and My Tired Brain are a couple of them. So in summary, I think I'm done forgetting. Sleep apnea is very common, but in infants, children, and teens with Down syndrome, it affects the heart, lungs, brain, and which also affects your IQ, mood, and attention. And it's really a lot of different factors. And so with that in mind, there's lots of factors. We really have to come at it with a really bag of different tools too. And those tools will change over time. So hopefully I've encouraged you to talk to people, your doctor or people around you about the concerns for sleep apnea. People are here today, so that's why. And to get tested and treated is really important. So I'll end with that. And then I think there's a few minutes for questions, I hope. So. Yes. Mm-hmm. There is. So the dental appliances, it's a good, I was really gearing this towards the children and teens. The dental appliances are really for adults mostly. You have to be skeletally mature, meaning your bones need to be done growing prior to really doing a dental appliance for treatment of obstructive sleep apnea, because it can change the bite for it. So the idea is the dental device will be bringing your jaw forward like this. So then your tongue, which is that big muscle, is brought forward as well. So I apologize. I should have mentioned that from the adult aspects of treatment of obstructive sleep apnea, but really not indicated so much for children and teens at this point. But. Yeah. That's good. I'll restate the questions. Yep, the question is, could dental appliances be remade at different points in time to be used for obstructive sleep apnea at different ages? It's a good question. You know, I don't, maybe, I mean, I don't know. Yeah, I don't have an answer to that, but that's okay. Maybe we will find that. Yeah, it's a good question. Yes, Jill.
What is the recommended rate for continuing with sleep studies after getting one before age 4 and then after that with your childhood and teenage years?
Yes, so the question is, what is the recommended kind of periodic check-ins for sleep studies? I'll look to also Dr. Stanley for this question, but really, you know, I don't think there is right now. I know really the recommendations are one before age 4 and then as needed. You know, I think of big times of changes. So if there, again, times of great growth are when you go from really childhood through adolescence. So that's a time of a lot of different facial growth. And so I think that that would be one recommendation. I think if you had one like less than age 4 or in school age, thinking again of the teenage years, because again, they probably are getting close to skeletal maturity and they've gone through puberty. And then adulthood, boy, I'm a pediatric sleep physician. So thinking of symptoms, I think, but I also told you it's hard to do symptoms. I think weight gain, you know, if there's differences in weight, that's another time to check in. I don't know. Maria, did you have any comments?
Yeah, I mean, I think your answer was really great. There is not a standard time course recommended, but I think the things that you mentioned make a lot of sense, and that really it's continuous monitoring for new symptoms. And sometimes those new symptoms are things that are not specifically sleep related, but just daytime behavior changes. And you mentioned like rapid growth, and weight, which I think are sometimes big factors. But I think whenever there's something new going on and we aren't able to explain it in some other way, it is always something to think about, because and in fact, I don't know how many of you probably heard of Brian Schicklein, but he runs a huge adult Down syndrome clinic in Illinois, and one of his mantras is always, every adolescent and adult has sleep apnea until proven otherwise. Yeah. So really and truly, it is just so common. I think that 60 to 100% number just tells you that lots and lots of folks are walking around with sleep apnea, maybe even without realizing it. And so it's something we're always monitoring.
Yeah, I'll just repeat for the audience. Dr. Stanley was saying there's not really, not for the audience, but the audience online. Sorry, in case you didn't hear, Dr. Stanley, is that there's not specific recommendations, but thinking of like change in behavior can do that. And I also mentioned after a procedure too. I apologize. I didn't think about it. You know, if there's an ENT procedure, that's another reason to do a repeat sleep study, but really thinking about it. And it's just so common at 60 to 100% to continue to reassess. But other questions? Yes.
I know that you mentioned that sleep apnea if a child is diagnosed with sleep apnea, is there ever growing and change? Is there ever a point where sleep apnea may go away, or is it typically once you have sleep apnea, you're probably going to have it?
That's a very good question. The question was, if you are diagnosed with obstructive sleep apnea at one time in your life, does that mean you'll always have obstructive sleep apnea, or can it go away? And it can get better over time. It also can get worse over time too. So that's, I think we talked about some surgical interventions that can make it better, like taking tonsils and adenoids out. So that would be a time where it may go from having a child could have obstructive sleep apnea, could get better, but then life changes too, the face changes, body changes, and it could come back too. And you know, I don't think there's a longitudinal study in Down syndrome looking at how that happens, which would be really intriguing to do. But so it is thinking, again, reassessment is just really important. So that was a really long answer to say it can get better, but it can also change again later. Yeah.
And I think besides the instrumentation, interventions that people can have, weight loss can sometimes also make a big difference.
Can make a huge difference.
Yeah.
Yeah, and
For somebody- if some-
move on. All right, sounds
All right,
good.
thanks, Barb.